Hi, everyone. So thank you for being here and welcome. We are now going on to session 5. My name is Sophia Leong. As mentioned, I'm a third-year medical student at the Kaiser Permanente School of Medicine. I use she, her pronouns. I have short black hair and I am wearing a dark gray mock neck t-shirt with a black jacket over it. I have the kind of tired look you get from being on an ICU rotation. And I'm sitting in front of a cream-colored wall in an office. So this session is about neurodiversity, and Dr. Feng, who I will be introducing, will describe the strengths-based model of neurodiversity and how this is used to create neurodiversity-friendly environments in the field of medicine. As a brief introduction, Dr. Lawrence Feng is an assistant professor in the Department of Psychiatry and Behavioral Sciences at Stanford University. He is the director of the Stanford Neurodiversity Project, director of the Neurodiversity Clinic, and principal investigator at the Feng Lab. His work, which focuses on autism and neurodiversity, traverses from multimodal neuroimaging studies to new conceptualization of neurodiversity and its application to clinical, educational, and employment settings. He received his PhD in chemical engineering from Cornell University and an MD from George Washington University. He completed his general psychiatry residency, child and adolescent psychiatry fellowship, and postdoctoral research fellowship at Stanford. So whenever you're ready, Dr. Feng, feel free to take it away.
Thank you, Sophia, for the kind introduction, and Peter for the invitation. So I'm going to share screen. And can you see the screen okay? Perfect. All right. Okay, so today I'm going to talk about neurodiversity in medicine, and the reason why I'm getting into the field of neurodiversity and autism is because of my son. 15 years ago, he got the diagnosis of autism, and after that, I decided that I'm going to devote my energy and time to do things that will be beneficial for him and others like him. And along the way, I also found myself to be to be neurodiverse as well. And this is my disclosure slide. I got funding from several agencies that Sophia talked about and did consultation for them. And I wrote a book on neurodiversity that I got royalties from APA Publishing. So today I'm going to tell you about what neurodiversity is and why it's important in the field of medicine. And I will introduce to you what the strengths-based model of neurodiversity is and what we did with the Stanford Neurodiversity Project based on the model. So first, what is neurodiversity? Neurodiversity is really more of a concept than a thing. It is a concept that regards individuals with differences in brain function and behavioral traits as part of normal variation in the human population. When we talk about neurodiversity, a lot of the time we talk about the neurodiverse conditions such as autism, dyslexia, ADHD or attention deficit hyperactivity disorder, but it doesn't end there. The motor disorders, the other neurologic conditions such as epilepsy and other psychiatric conditions are all under the umbrella of neurodiverse conditions. And when we are talking about diversity and human traits, oftentimes we would think about the bell-shaped curve. So who is neurotypical and who is neurodiverse and so forth. So in the middle, 68%, the green area is the average area. So basically on the right-hand side will be above average. On the left-hand side will be below average. If we think about one of the most used way of assessing human abilities, it will be probably IQ. And right off the bat, I just want to tell you that this is very limiting, and I'll tell you why I say so in the next few seconds. Basically, for people that have IQ of 85 to 115, they have average IQ. Someone that has IQ of 130, pretty smart. 145 and up at the genius level. On the other hand, people with intellectual disability will have IQ of below 70. And I say that IQ is a imperfect measure because it only tells us very limiting domains of intelligence, such as visual spatial, verbal linguistic, and logical mathematical. It doesn't really tell us anything about anything else. So Howard Gardner at Harvard University have used this theory of multiple intelligence in the last few decades to illustrate to us that there are other domains of abilities, such as musical rhythmic, bodily kinesthetic, or athletic. Naturalistic is basically very good in working with the nature. Interpersonal is the ability to relate with other people. Intrapersonal is the ability to understand self. Existential is the ability to understand your own existence, the universe's existence, etc. So one can imagine that each person can have some ability in all of these domains. So we can have something that we can call multiple intelligence profile. To illustrate the MI profile, we go to someone that we all know, Albert Einstein, who is the genius of the genius. So what is his profile like? Musical rhythmic, almost above average, he played the violin. Visual spatial, way up here at the genius level. Verbal linguistic, not so high. He actually didn't speak until 4. Logical mathematical, he will be pretty lonely in his own island somewhere around here. Naturalistic, average. Intrapersonal and interpersonal, based on the history books, he struggled quite a bit. Bodily kinesthetic, average. When we are looking at this profile, what you can see is that the genius of the genius is not superior in all the different domains. He, however, is very good at a couple of domains that he is very passionate about, and because of that, he really distinguished himself and really bring a lot of good to the society. And many people are like him. Because we are running out of time and we have a lot of materials. I'm not going to tell you who all of them are. In other presentations, I go through all of them. But there are a lot of scientists in the physical sciences, biological sciences. Like this one is Barbara McClintock, who won Nobel Prize in genetics, and this is Charles Darwin, father of evolution. And also other people in other fields, like in the arts, in the music, in the musical field, and some are writers, some are entertainers, etc. And one thing that is in common is that they are all very passionate about what they are doing. Because of that, they really get to much more depth than other people. And they really change the society for the good because of their passion and their special interests. And also the other thing is many of them are on the autism spectrum. Many of them also were born before 1943 when autism is coined as a term. So we can only say that from the history books, they have the profiles that are consistent with autism. And when we are thinking about these individuals, we know that they have a lot of strengths. And sometimes when people talk about autism in the field of medicine, they think about challenges all the time. So the challenges that we see in autistic people include perseveration, which is when someone is doing something over and over again and it's not getting anywhere. However, if the results are good, you're going to call it persistence or perseverance. Seeing big picture may not be their natural instinct or their tendency. They tend to be drawn to details. If you are wanting someone to be solving a problem that requires details, then you may actually want a person that has this profile. So the autistic characteristic of very much detail-oriented will become a strength. Most autistic people have fewer interests, but when they are interested in something, they would know everything about the field. Perspective taking is not their natural tendency. They tend to be very concrete and honest. They interact with others differently, but at the same time, they are very one of your most loyal friends. So one list of both challenges and strengths at the same time. And what can make it possible for the strengths to be manifested most of the time would be about the environment. When the environment is neurodiversity friendly, when people understand the strengths of autistic individuals and allow autistic individuals to show their strengths and understand their challenges, then you're going to be able to see a lot more good from autistic people. This list of people don't have autism, they have ADHD, and including JFK and some inventors such as Alexander Bell and Thomas Edison, and some athletes here and entertainers here, and also a CEO here, Richard Branson. So one thing that they say often is that if they don't have ADHD, they are not going to be as successful as they are. And then we have another list of distinguished individuals, including our very first president and an alum of Stanford, Charles Schwab, who has dyslexia. And also other people that are in the sciences, like Nobel Prize winner Carol Greider, and here are two physicians, Toby Cosgrove, who is the president and CEO of the Cleveland Clinic, and Stuart Udofsky, the past chairman of the psychiatry department at Baylor College of Medicine, together with other journalists and entertainers. So one thing that is quite remarkable when you're looking at this is that we, in the field of medicine, we know that people that have dyslexia are having a lot of trouble with reading, writing, rote memory, and so forth. But these physicians are at the top of the field, of our field, and they overcame their challenges and make it their strengths. So next, let's ask why is it important for us to understand neurodiversity, especially in the field of medicine. So one part of it is basically we know that there are a lot of people that have the diagnosis of autism, and I'll show you some numbers. And the other side of things is autistic individuals and other and individuals with other neurodiverse conditions are already in our midst in medicine. So I'll go through the slides so that you get more perspectives. How common are neurodiverse conditions? Now, the prevalence of autism is close to 2.9% based on the last report from CDC. Dyslexia is much higher, 13 to 14%. ADHD is somewhere in between 5 to 7%. And so if you are looking at the total of these conditions plus the conditions that I mentioned earlier, the neurodiverse population would be one of the largest minority in the world. And why is it also important? It's not only about there are a lot of neurodiverse individuals. They also have a lot of barriers to healthcare. And we as medical providers should know how to take care of them. So this is a paper that came out in 2022 that talk about that. And basically there were about 500 autistic adults that answer questionnaires, and they are compared with about 160 non-autistic individuals. So what they found was that the barriers to healthcare for autistic adults include the avoiding and delaying general practitioner visit, and 62% of them have indicated that they have difficulty using the telephone to book an appointment. They 56% feel they don't want to go to see a doctor because they feel they do not feel understood. So more than half avoid doctors because they don't feel understood. And also the 53% have difficulty communicating with the doctor during the appointment. The number is even higher than difficulty communicating with the reception staff. And then there is also the category of communication differences. The 78% of them say telephone generally avoided, and 61% voicemail generally avoided. And what are some of the consequences? One consequence is that you can see the green is autistic individuals compared to the non-autistic individuals. And this is the y-axis is the percentage of individuals that are affected in this way, or they feel they are affected in this way. So almost 70% feel they have untreated mental health compared to 20% in non-autistic individuals. And also untreated physical health is way up there in the 60s. And also untreated life threat. This is serious, about 1/3 of them. And almost 40% of autistic individuals, they do not attend screening. So all of that is really very alarming statistics. On the other hand, there is also a study that is focusing on physicians that's conducted by Kaiser Permanente. And they have almost 800, they have 852 doctors, including over 400 primary care provider and over 100 OBGYN doctors and almost 300 mental health providers. And they asked this question: which of the following patient characteristics would lead you to explore the possibility of an autism diagnosis? So I think all of us have gone through medical school and learned that there is limited eye contact. So you can see that in terms of the percentage, all three groups did pretty well. Has a flat affect, it's only 60% or so in all three groups. And there are other questions that are more alarming, that are statistically significantly different between groups. When someone is sensitive to touch, only less than 60% of primary care provider and OBGYN doctor would think that there is a possibility for autism. Well, autistic individuals have sensory aberrations in all different senses. So it is definitely a possible thing. And similarly, light and sound is also about 1/2 of the primary care provider and OBGYN doctors. Mental health providers did a little bit better, not too much better. And also other questions about monologue style of communication. This is actually very common in autistic individuals. And the numbers are also fairly low, only 50s in the OBGYN doctors, about 60% in primary care provider. And also one last one is unusually direct, very blunt maybe. Very few providers actually think that this is maybe a possibility, a possible communication style for autistic individuals. So this leads us to think that there is a lot of really inadequate detection of diagnosis of autism that may be actually affecting the care with the autistic individuals, autistic patients. And there is also some questions about when you suspect autism in a patient, do you do a particular thing? So about 90% of mental health providers would probe about developmental history, but not so high in primary care providers, very low for OB/GYN doctors. And like consulting with a colleague, it seems like it's a similar trend that is very low, but is much lower than the previous question. So a lot of this is really about not really taking autism as a diagnosis into the care of the patient. So what are some things that can be done to do better? So Mary Doherty and her colleagues have published a paper that talk about this. And some of the strategies could be about communication. You need to be clear and unambiguous because they are very concrete. And sometimes e-consultation is better for them. And sometimes they write better than actually talking. And in terms of the sensory modality, thinking about sensory audits, thinking about appointment times that can be like facilitating the attendance, and also allowing time to process information. And just like if someone is on the autism spectrum that is sensitive to fluorescent light, a simple thing could be that you really dim the light. But the first thing is you have to ask the patient. And also predictability. People on the spectrum, generally speaking, they have cognitive inflexibility. It is very common. And because of that, when there are change in plans, it's going to be difficult. So basically provide information on what to expect is going to be helping with the relationship. So if all of these can be taught to medical providers, then that will be quite helpful. So Lauren Clark, a medical student here at Stanford, and I published a paper last year. It's a systematic review on the impact of autism-related training programs on physician knowledge, self-efficacy, and practice behavior. So we had many papers in the beginning, several thousand papers, and then distilled down to 17 papers that meet the criteria, and found that, first of all, there are not really that many studies that have the physician training on autism or focus on autism. And only 76% included physicians, 12% for the residents, and other 12% for the medical students. And among the 13 that are including physicians, they generally so basically 23% have included at least one specialist physician. So it can be psychiatry or neurology. And then the other studies are pretty much widespread to mostly primary care providers. So you can see that the specialists are generally not trained. And psychiatry, neurology are the only represented specialty. And the other subspecialties are not included, or they are not. We have not found that there are any studies that describe the training of any other specialists. What we also found was that there's only 15%, including the pediatricians only, and also around 2/3 of the studies exclusively focus on pediatric patient population. So what that means is that there is very little on autistic adults. In fact, none of the studies, not even one identified, is focusing on autistic adults. Everything is about kids, because autism has been a childhood disorder for many, many years. But these autistic children grow up over the years, and our literature is not really keeping track on the developments fast enough. And also among the training programs that we have found, some of them are online, some of them are in person, some of them are hybrid, so there's a big range. And the duration of the training is also very variable, from only a few hours to recurring meetings for many months. And among all these more recurring meetings, the most common model is called the ECHO model. And these are online meetings with didactic component followed by case-based presentations. And they're usually led by autism specialists. The frequency and duration can range from weekly for 3 months to bi-monthly meetings for a year. And what we found was that physician knowledge in about 60% of them would suggest that the physician knowledge on autism is generally improved after training. And about 1/2 of them measured physician self-efficacy. And all of the papers have shown that whatever kind of training that's specialized in autism, they all make the physician feel they can take care of the patient better. And then 65% of the papers have reported some aspect of actual physician behavior change. And among them, 67% of the studies report significant increase in autism screening rates, and only 2 reported no significant changes. So definitely, the self-efficacy is most robust data from what we are seeing in terms of the success in improving outcome. But the actual physician behavior, we do not see like 100% increase. And what we also don't see is there is no study that also measure the effects of these training programs in the patient outcomes. So far I've talked about a lot of things that are related to how to take care of patients and so forth, but neurodiverse colleagues are already in our midst. And some of you might have watch Sean Murphy in The Good Doctor. That's not the only example, and that's a fake example, but there are actually true examples. Actually, according to a survey in UK, they have found that about 1% of the doctors in the United Kingdom are on the autism spectrum. And that's actually very comparable to the prevalence of autism in UK and many other countries. In the last few years, there's a group called Autistic Doctors International that have published several papers that talk about autistic doctors in various different ways. And they talk about anesthesiologists, primary care provider, even psychiatrists. And they even got traction on getting Royal College of Psychiatrists to make their equality action plan to include neurodiversity. So there is really some exciting things that is happening in UK. It would be great if our country can also do the same. And this paper is about the doctors with Asperger's. This doctor was saying, I think there was an awareness that explained why things that had not worked out as they should. I think it also had, unfortunately, a negative impact on the perception of other people on them, because they also experience, oh, you probably can't do that, almost disabling them because of the diagnosis. So it was a two-edged sword. So basically explaining that the disclosure, it can actually hurt the physician on one hand. On the other hand, the awareness is great. Neurodiversity awareness is definitely great. But for this physician, sometimes this is a worry. And what are some of the other things that are associated with these worries that may be relevant? There is a very common phenomenon called camouflaging. So basically, in autistic individuals, sometimes they cope. Sometimes they use coping strategies in social situations. So they would hide behaviors associated with autism, use explicit techniques to appear socially competent, and find ways to prevent others from seeing their social difficulties. And this is especially concerning because autism, camouflaging is directly proportional to depression and anxiety. The x-axis here is the camouflaging score, and you can see the y-axis here. And this is especially important for autistic females. This is a study that my group completed a couple of years ago. And it is also replicated by other groups in University of Cambridge, in that females on the autism spectrum camouflage a lot more than males. So with the last 10 plus minutes, I'm going to talk about the strength-based model and what our group has been doing. It is the strength-based model is very different from the disability model or the medical model, in that the medical model is really about the diagnosis. The strength-based model is about what the person can do. And this is very important, not only for the people that have above average IQ, even for people with intellectual disability and autism. In this study by Rabin, we can see that in many different domains of abilities, with or without intellectual disability, autistic individuals can have significant abilities. And this finding actually is started from all the way in the beginning when Leo Kanner, who coined the term autism, who already told us about the memory skills and the musical abilities in the first 11 cases that he reported. So there are four components of the strength-based model. The first is positive psychology, and then positive psychiatry, Gardner's theory of multiple intelligence, and Chickering's 7 factors of development. And we want to consider neurodiverse conditions as conditions rather than disorder, and acknowledge challenges instead of deficits, because as you may remember one of the slides that I showed you before, if you are focusing on only the deficits and call it disorders, then you're only going to stay in the challenges. The characteristics of autism will not be pivoted into strengths all the time. So that's the main reason why in the strength-based model, this is what we emphasize. Another thing is we want to apply strength-based model across entire spectrum of neurodiverse conditions. For the sake of time, I'm only going to tell you about the positive psychiatry as one of the components of strength-based model. Positive psychiatry is about positive attributes and strengths, but traditional psychiatry is about what's wrong, the pathology, the risk factors. I know I have 5 minutes left, but I'm going to go beyond 5 minutes a little bit, just to make sure, but I'm aware of the time, thank you. So protective factors is what we want to focus on in positive psychiatry versus risk factors and what's wrong. Also, in positive psychiatry, we want to increase well-being and growth. We want to make it by delivering psychoeducational intervention. In contrast, in traditional psychiatry, the approach is generally reactive. We treat symptoms by using medications and short-term psychotherapies. So basically, the preventative approach of positive psychiatry has been largely ignored in traditional psychiatry. So now I'm going to tell you a little bit about the Stanford Neurodiversity Project. It's a special initiative of the psychiatry department. And basically, it is very much consistent with what the ideal initiative is. It is about inclusion, diversity, equity, and access in the learning environment. And all of our programs within the project establish a culture that treasures the strengths of neurodiverse individuals, so as to empower neurodiverse individuals to build their identity based on their strengths, and that can enhance their daily living skills. We want to attract talented individuals, neurodiverse individuals, to come to Stanford to study and work, and also to coming to the partnering organizations that share our philosophy. We also train talented individuals to work with the neurodiverse population. Ultimately, we want to disseminate this model for maximizing the potential of neurodiversity, not only for the neurodiverse individuals, but for all of us, because they have so much to bring to the table. So I'd like to thank Dr. Laura Roberts, especially, and many staff members and students and staff that have been contributing in the project. And I also want to tell you that we are using an ecosystem-driven approach. So we identify the people around the neurodiverse individual. For example, in the education setting, there are the professors, coaches, classmates, roommates, who can make the workplace, the educational setting more neurodiversity friendly. And the school officials and the school community can do the same. Employment setting, similarly, the supervisors, job coaches, colleagues can make the immediate environment more neurodiversity friendly. and the executives and the work community can even make it possible in a larger environment. We have several initiatives in our program. This will take a long time to cover, so I'm going to just tell you a little bit about what we have been doing. One part of what we are doing is we have a special interest group for neurodiversity that we have started in 2017. And every month we have been inviting someone who's knowledgeable in some aspect of neurodiversity to come talk to us. And if you are interested, join us by going to our website and sign up for the special interest group for neurodiversity. We are meeting on the third Monday at 4 p.m. Pacific time. And in addition to the special interest group, thanks to Dean Miner and Dr. Roberts, who have been very supportive to our Stanford Neurodiversity Summit. In the past 3 years, this year is our 4th year, we have thousands of people joining us from all over the world. And every year we have over 100 speakers talking about various aspects of neurodiversity. And this year is going to be held October 1st to 3rd. And I'll skip the educational work that we have been doing and jump to the Neurodiversity at Work program, which is funded by Autism Speaks as well as the California Department of Developmental Services and California Department of Rehabilitation. And we are basically using our curriculum that we have developed to help employers as well as the neurodiverse individuals to understand how to work with each other and make the workplace more neurodiversity friendly. And we have done that in the School of Medicine with Rebecca Edwards is one of our first participants of our project. And she is working in the Wuxi Neuroscience Institute. And she even got a promotion in the last year. And this story was talked about in Stanford Medicine, probably in 2021, a couple of years ago. And we also collaborate with organizations such as Google. This is an article from Forbes, from The Hill. And we also work with many other organizations within Stanford, as well as outside Stanford. So basically, what we do is we, as I mentioned, we use a two-prong approach to support both the employer and the neurodiverse individual. And we have a support system for the team that will support the neurodiverse individual, as well as another coach that's worked directly with the neurodiverse individual. So this model is basically used to show that the retention for autistic individuals are better with our curriculum than if we use business as usual approach. And this is basically a sample curriculum. I'm going to just jump to the end here and just want to let you know that using the strength-based approach, Dr. Gauls and I are going to start teaching CBT providers on how to work with autistic adults. And if you are interested, go to our website and or scan this QR code. Our course will start on June 8th. So in summary, the neurodiverse community is one of the largest minority group in the world. The neurodiverse individuals have so much to offer to the society. Their specific challenges can be overcome. There are significant barriers to healthcare in autistic individuals, and there are autistic doctors already in our midst. And we have established the strength-based model of neurodiversity which is being implemented in the Stanford Neurodiversity project. So feel free to join us in our special interest group and let us know what you would like to do. By working together, we can make a difference to the neurodiverse community and beyond. Thank you for your attention, and with that, I will stop here and answer any questions that you may have.
All right. Well, thank you so much, Dr. Fung, for that presentation. It's great to see, how much work is being done to, support awareness for neurodiversity. So what I'm seeing in the questions right now, we have some concerns about funding from Autism Speaks. It is sometimes considered an organization that has promoted some anti-autistic messaging. So could you maybe speak towards, some of your thoughts about the organization and, getting funding from them?
Yeah, so I got asked about this many times before. I think what we want to focus on is what good we are doing from the funding that they provide. And they have a history of using different kinds of communications that have been not been favorable in the autistic community, and they are gradually really moving away from those communication using different words, and their philosophy has also changed. So one thing that I feel is that in the autistic community, the neurodiverse community, we want to learn from history, but we also want to know that we will be better off if we work together. And when people are already making changes and they are really staying away from the bad thinking from before, to me, I would just forgive them and then say we just need to do better.
Well, thank you so much for, sharing your perspective on that. I think a lot of the audience will appreciate, you being forthcoming about the funding and also, sort of welcoming this idea that people can change. And I think another question that sort of was interesting to see is, just addressing anti-neurodivergent education in the healthcare community. For example, I think something that's disseminated a lot is if someone is having an autistic meltdown, you should physically restrain them. And the submitter of this question also mentioned, many online talks about autism and other forms of neurodiversity are filled with stereotypes and worst practices. And, what can providers with disabilities do to counter these?
Well, I think the first thing is the providers need to be educated themselves. As I mentioned, the medical community is not well educated on neurodiversity, on autism, and many other neurodevelopmental conditions. So it is pretty clear from what we have done from the systematic review that Lauren Clark and I have done, as well as the data that I've shown. There is really a big need for the medical community to be more educated. So when the medical community is more educated, then you'll be in a better position to actually bring people back on the right track together. So I think it's a two-step process. One is to get the medical providers to know what they are supposed to know about autism and neurodiversity. And then after that, we will be able to correct the misconceptions. The social media is so easy to post things that are completely false. And I think medical providers have that responsibility to figure out what is actually correct and let the patients that we work with know and their families know and other people that we know that can contribute to a better place for all of us.
All right. Well, again, thank you for sharing your thoughts, Dr. Fung. As we're coming to the end of the session, I saw a comment that said, for those who continue to be wary of Autism Speaks, there's also Autistic Women and Non-Binary Network, and there's also Autistic Self-Advocacy Network for more references. So I just wanted to, state that for everyone to hear, that there's resources out there for people, both autistic and not, that are not Autism Speaks. And so with that, I think we will move on into a break. And after the break, we will have the breakout sessions. Thank you, everyone.